بسم الله الرحمن الرحيم. لي عظيم الشرف إن أنا أكون متواجد مع حضراتكم اليوم. I would like to thank the committee of the conference that give me this chance to be with you in this conference online from Riyadh, Saudi Arabia, to talk about the maxillary sinus, which is the conductor of orchestra of all paranasal sinuses. As you know, the maxillary sinus is the most easy accessible sinus, and it's the first sinus for any intervention in endoscopic sinus surgery. This sinus also is a landmark for many structure inside the nose, like sphenoid sinus. It's also if you have lesion in the pterygopalatine fossa or lesion in the infratemporal fossa, should be accessed through these sinuses. So we must study this sinus well, which is just below the eye and above the teeth. We also have important landmark, which is the nasolacrimal duct. We must take care while surgery in this sinus to avoid complications like teary eyes. So we have many scenarios in this lecture, which is a specific disease like odontogenic disease, minimal disease, recalcitrant maxillary sinusitis, diffuse nasal polyposis, fungal ball, and the tumor, which is easy accessible endoscopically. What is the approach for surgical procedures? Maybe antrostomy or maxillectomy or sinuplasty, balloon sinuplasty. And finally, do not forget topical therapy. Let us first by the odontogenic maxillary sinusitis. Any unilateral maxillary sinusitis should be expected as a dental origin due to dental caries or infection from the teeth. As you can see, impacted root of the teeth inside the maxillary sinus, and there is bone defect here between the sinus and between the teeth. So this is odontogenic in origin. How can we manage or deal with this case? Either by medical treatment, you must start maximum medical treatment, antibiotics that invade the sinus like rifampicin or doxycycline and metronidazole. If not improved, so you can go for this surgery as in this case. In this case, swab taken from the sinus. It was staph aureus, resist to medical treatment, many antibiotics. So failure of medical treatment, you can go for surgery. When you go for surgery and opening of the sinus, you will find pus inside the sinus. As you can see here, this pus collection inside the sinus due to teeth infection. You may need with you maxillofacial to remove the teeth also, and if you have fistula, you must deal with it and do closure for the fistula in this case. This is odontogenic maxillary sinusitis. What about the minimal disease of maxillary sinusitis? As you can see here, how can we deal with it? By maximal medical therapy or minimal invasive surgical techniques like FES, which may be uncinectomy only, and middle meatal antrostomy. Balloon sinuplasty also is a good solution for in some cases of minimal disease of maxillary sinusitis. So according to the disease mucosa of the maxillary sinus, we have 3 grading and endoscopic finding. And how can we deal with each grade? If the mucosa normal or slightly edematous mucosa and the patient is complaining, you can enough do uncinectomy and visualization of the natural ostia. But if you have small polyps or insignificant eosinophilic mucus, you can enlargement of the ostia. But if you have severe polyposis and tenacious eosinophilic mucus, you can do intranasal mega antrostomy for that. We have many factors which affect and the outcome of the maxillary sinusitis. The first one, as we said, which is staph aureus. Staph aureus, as we said, and the Pseudomonas can be resist to treatment if there is infection inside the sinus, as the drug penetration is very low. If you have biofilm, this is the antibiotic cannot reach the bacteria because of biofilm. So you need mechanical or physical dispersion for this biofilm. Other factors like osteotic bone or inflammatory polyps, eosinophilic mucus, all of this affect the outcome of the failure of the sinus disease. So what is the approach for the maxillary sinusitis? We have many approaches, started from the middle meatal antrostomy, mega antrostomy, partial endoscopic medial maxillectomy, total endoscopic medial maxillectomy, a transseptal approach, and endoscopic Dinker's approach. Caldwell lock, sometimes we can use it, especially with dentist in case of dental infection. Midfacial degloving and the lateral rhinotomy, we didn't use too much nowadays because of the era of endoscopes. This is the fungal ball in the left maxillary sinusitis. As you can see here, you can remove the advantage of the fungal ball. If you remove it, the incidence of recurrence is very low because it's not non-allergic disease, and the most sinus affected, which is the maxillary sinus, and at a lesser extent is the sphenoid sinus. So if you must remove the fungal ball completely, and the incidence of recurrence is very low, as you can see in these videos after preparation of the patients and medialization of the middle turbinates, exposing the uncinate, removing of the uncinate, and removal of the fungal ball. As you can see, the sinus is filled of fungus. Is non-allergic. You can remove the fungus by many ways, either piece of gauze, rolling piece of gauze, or by seeker, or irrigation by baby shampoo. If it's difficult to be accessed, and now we remove all of the side of the fungus from the left maxillary sinus, as you can see here. Removal of the fungal ball from the sinus. And this is the condition of the sinus using 70-degree endoscope. After removal of all the fungal ball, it's completely free from the fungus, and the incidence of recurrence is very, very low. Another important thing, which is the antrochoanal polyp, which is the most affected sinus, which is the maxillary sinus. In this child, 13 years old, represented by nasal polyps, as you can see, and the polyps extending to the oropharynx is like a ball in the oropharynx, and this is the CT scan, axial and coronal, and this is the endoscopic view. You can see the stalk of the polyp, and this is the choanal part, and here is the antral part inside the left nasal cavity of the child, 13 years old. Here, we must know where is the origin of the antrochoanal polyp. If we need to do pre-lacrimal approach or no need. Only widening of the ostia. This is the accessory ostia, and the polyps are rising from the ostia. In this child, we can reach easily to the origin of the polyps, but we remove it from the nasal, from the oral cavity, not from the nasal cavity, because it was huge polyps. The pedicle of the polyps cauterized to prevent recurrence. We use tonsillectomy set to remove the choanal part of the polyps from the oropharynx, as it's very huge because it's a child 13 years old. This is about the antrochoanal polyps. What about the recurrent antrochoanal polyps? In recurrent antrochoanal polyps, we need pre-lacrimal approach. In pre-lacrimal approach is very important, in which we open a window inside the maxillary sinus anterior to the lacrimal duct, and we can reach to the origin of the polyps and the removal of the polyps and the cauterization. As you can see here, incision in the mucosa, removal of the bone, exposing of the nasolacrimal duct. Take care not to injure the lacrimal duct here. And this is a case of recurrent antroquanal polyps. We do pre-lacrimal approach for these polyps. And here is the incision of the inferior turbinates, removal of chisel to remove the bone on the anterior wall of the maxillary sinus, and the opening of a window anterior to the lacrimal duct, and to go inside the maxillary sinus and opening of the maxillary sinus. As you can see here, this is the origin of the polyps. This was recurrent polyps, so this polyp should be removed and cauterized. Another approach to the maxillary sinus is the canine fossa. If you draw line across the mid-pupillary line and along the ala of the nose, just above the canine fossa, you can insert your trocar and the cannula. You can insert your endoscopes and insert the shaver to reach a difficult accessible area in the maxillary sinus. Important in some polyps also and some fungus. This is a case of inverted papilloma of the maxillary sinus also. Here we have another modified, what's called modified transnasal endoscopic medial maxillectomy, in which we can preserve the nasolacrimal duct and the inferior turbinates and opening the maxillary sinus with preservation of these two important structure, which is the nasolacrimal duct and inferior turbinates. This approach is called modified transnasal endoscopic medial maxillectomy. And in case of inverted papilloma, we can do modified Dinker's approach or total endoscopic medial maxillectomy. Here, the left nasal mass arising from the maxillary sinus. You can see CCB is a characteristic of MRI of the inverted papilloma in these patients, and we can go for endoscopic medial maxillectomy, and we remove the medial wall of the maxilla using endoscopes, drilling of the anterior wall of the maxillary sinus. As you can see here, removal of the bone using lux forceps, removal, and now removal of the anterior wall and the medial wall of the maxillary sinus. And it's very easy accessible to expose the lateral wall of the sinus, posterior wall, anterior wall of the maxillary sinus, and you can easily remove all the tumor, and you can detect where is the origin of the tumor. It's also very easy to cauterize this tumor, and you can remove all the tumor as in block mass from the sinus to prevent a recurrence of this tumor. Here, using the inferior removal of the inferior turbinate together with the tumor to remove it as an in-block mass to prevent a recurrence. And then cauterization using unipolar cautery, cauterization of the base of the tumor and the drilling of the cancellous bone of the tumor. Then how can we deal with nasolacrimal duct? In this, you must deal with the nasolacrimal duct also. You must remove the bone anterior to the lacrimal duct. Here is the lacrimal duct, as you can see here. This is the lacrimal duct, and this is the tumor attached to the bone anterior to the lacrimal duct. Should be dissect this bone and remove it, and the lacrimal bone here should be cut superiorly in the bone, not inferiorly, to avoid fibrosis. So it's superiorly inside the bone and to avoid obstruction or fibrosis, as you can see here. This is how can you deal with the duct if there is tumor of the sinus. Finally, what is the top 10 causes of maxillary sinus surgery failure? We have obstructed natural ostia, persistent disease in the frontal or ethmoids, we have biofilm, foreign body, we have incurable mucosal disease, wrong primary diagnosis, maxillary osteitis, or mucus maltransport, immunodeficiency patient, and finally, you must know the pathology. You will treat it medically or surgically. What is the choice, surgical choice, and what is the top 10 failure of surgery? Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. Greeting from Riyadh.